We're going to start the next panel, which is on issues in Latino health and community. Fortunately, we had one cancellation due to a personal emergency, so our speakers for Dr. Byung Lee, which we're sad to miss this, but we will begin then with Dr. Amanda Marin Shalom and follow with Dr. Sylvia Jalil Gutierrez. And let's welcome them.
Hello, everyone. I know this is the time of day where we need another cup of coffee, so hang in there with me, all right? So I am in the psychology department. I did my postdoc at Columbia University Medical Center, and the research I'll be presenting today is from collaboration with that data that I collected during my postdoc. So social support, diet, physical activity among Latina breast cancer survivors. Just a little fact, in our lifetime, 1 in 3 women will develop develop any type of cancer, and 1 in 2 men will also develop any type of cancer. So cancer will be in your life one way or another. So a little background, what I'm presenting on today, breast cancer is the second most common cancer diagnosis among women residing in the United States. The first one is skin cancer, which people don't think about when we're out there tanning. Hispanic and Latinas have low incidence of breast cancer. However, it's the #1 cause of death. They tend to be diagnosed with late-stage cancer from several reasons. One is underutilization of mammography, larger tumors, hormone receptive negative tumors, which relates to how they're being treated during chemotherapy, and then also delays in follow-up. What does that mean? That means they get a mammography, the doctor says, please come back, we need to get a biopsy from you, and you take time from the mammography to the biopsy, the cancer can grow within that time. Also, you can have a delay from when the biopsy comes back and says, hey, you have cancer, we need to start treatment. That can, a lot of women don't go immediately to start chemo or radiation, whatever their treatment regimen is. So all these delays, what does it do? It leads to bigger, larger tumors that are harder to treat, especially for minority populations that don't have access to healthcare or even understand how to navigate the healthcare system. And the survival rates for breast cancer are actually pretty high. If it's found early, about 99%. Okay. Once it starts to spread outside of the breast to other regions or organs, it goes down to 28%. That's why there's a big emphasis on prevention. Okay, so some background. There have been numerous efforts to understand and improve breast cancer survivorship outcomes through personal life changes such as diet and physical activity. The American Institute for Cancer Research and the American Cancer Society, they have recommendations for diet and physical activity that are less likely to be followed by minority cancer populations such as Latinas or Hispanic women compared to non-Hispanic women. And here are some And these recommendations that they are requiring or recommend for breast cancer can also help alleviate other chronic diseases that they suffer from, such as diabetes or cardiovascular health issues. And here are some of the recommendations. So here is the American Institute for Cancer Research. You can see here when you're eating, you should try to have a colorful plate where most of your plate is taken up by grains and vegetables, and maybe a quarter of that plate should be protein. It's usually the other way around, okay? You should also try to limit your salt, your oil, and try to get physical activity. And when we think physical activity, it's not necessarily going to the gym. It's literally getting up off your sofa and walking, okay? 15 to 30 minutes to go somewhere. So the recommendation is about 150 minutes a week. That's literally 30 minutes a day of walking at a moderate pace, okay? That is the recommendation. Yet most of us don't get it because we drive everywhere, okay? So social support is one potential mechanism that can encourage healthy lifestyle. Social support is meant multidimensional, and it comes from different social networks, especially in the cancer treatment process. It can come from your family, it can come from the health professionals, social workers, whoever's helping you along the cancer trajectory. Social support, specifically from the family, tends to be highly regarded within the Latino culture. However, and it's seen as a vital component for the cancer survivorship process. However, it's understudied when we work on Latino Hispanic population in cancer. So I took the data. So I took the data that we collected social support and analyzed it, and I'm going to give you a little background on what studies have looked at social support. So studies to date have really been inconsistent in showing that higher levels of social support among cancer survivors is associated with higher levels of physical activity and healthy eating. And most of these studies have been conducted in majority white cancer populations, and even outside the cancer populations have been just pure white populations. So studies specific to Latina breast cancer survivors have found that, yes, with social support from family, there have been increases in vigorous intensity physical activity. And vigorous intensity physical activity means that you're like running. It can be anything that gets your heart rate to like the pace of running. So dancing, lifting heavy things. Another study, which this is the precursor, is called Cocinar para mi Salud. It's a precursor to the Mi Vida Saludable study that I'm going to be reviewing today. They found that there was no significant effect between social support and diet. However, perceived social support for healthy eating was highest from the spouses and children. So this study examined the associations between social support from different sources, family, friends, and a significant other. I'm talking significant other. It doesn't have to be an intimate relation. It's just somebody that is special in your life, okay? It could be a best friend. With physical activity and diet behaviors in Latina, Hispanic breast cancer survivors. So we hypothesized that higher levels of social support would be associated with higher levels of physical activity and healthier eating. Also hypothesized that these associations would be more frequent with social support from family and a significant other. So the subsample of participants that I analyzed came from a baseline data collected from a larger randomized control trial, or an RCT, and a physical activity intervention. It was called Mi Vida Saludable. If you want to look up the clinical trials, there's a number for you, since it's paid by your taxpayer dollars. The inclusion criteria, they had to be female, 18 years or older, self-identify as Latina or Hispanic, self-reported history of stage 0 to 3 breast cancer, because after 3, it implies that it has spread to other regions of your body. No evidence of reoccurring or disease that has spread to other regions of your body. They had to at least finish treatment 90 days prior. They had to be non-smokers. We also screened them for having to have consumed serving 5 or less servings of fruits and vegetables in the past week, or engage in less than 150 minutes of moderate activity in the past week. So they can meet either or. So the sample that I was able to pull that actually had social support data, because as we know, not everyone completes all the measures. So 85 women completed the social support measure, and the standard age was about 55, standard deviation of 9.63. Mostly Dominican heritage, because if anyone knew New York City, we did the study in Washington Heights. That's where Columbia University Medical Center is. So the majority of the participants, around 76%, they're Dominican. The measures that we used for social support was a multi-dimensional scale of perceived social support, which measures support from family, friends, and a significant other. We also did 7-day physical activity recalls, which is it's in person, and yes, in person. And you ask them about their activity from the past 7 days in increments of 10. So you ask them, and on Monday, what did you do? And they go through your whole day to collect the activity, because it can be any activity. It doesn't have to be in the gym. It doesn't have to be leisure activity. There's some people that have jobs that are very vigorous, active, and that counts for your physical activity. We also used 3 24-hour diet recalls. What is that? We asked them within a 2-week period. We call them 3 different times over the phone, and we train them how to measure their food. We give them pamphlets, and we call them, and we ask them what they ate in the past 24 hours. And we put it into a computer system, and that computer system has all the calories for every single meal. It has Jack in the Box in there. It has McDonald's. It has all the foods you can think of in there with all the nutrients for us to analyze later. The analyses, first I conducted bivariate correlations to see where there was associations, and also then we did linear regression models with only the statistically significant associations to see if these associations held with covariates of acculturation, income, education, and age. So here's the descriptors. We found that they had high levels of moderate activity, 209 minutes on average. Total moderate to vigorous physical activity, 268 minutes on average. but hard activity, about 30 minutes on average, and very hard, 18 minutes on average. And again, so one of the limitations to the study, you're not going to see these numbers across Latinos in the United States. These are New York Latinas, where you're forced to walk everywhere, okay? So diet, we found the average caloric intake was lower than the recommendation of 2,000 calories. Some may say, well, there's self-report bias, social desirability. However, we had a very stringent protocol to collect this data, and this is not the first time where we find that these women have lower intake, and it can also be due to socioeconomic statuses and availability to eat the food as many calories as they want. The average intake of fruit and vegetables was slightly below the minimum recommendation of 5, and average fat intake was within the recommendation of 20 to 35% of a diet based on 2,000 calories. And then the energy density of participants was on average low, which is good. So what are energy dense foods? Energy dense foods are all the foods we love to eat. Potatoes, yuca, corn, all the things that have low energy density are the things we don't enjoy eating. Anything with whole grains, okay? Or fruits and vegetables. Social support scores were on average high. The highest you could score on social support was a 28, and they were 20, 20, and 22, sorry. So here are the results based after that. So we first found, these are the bivariate correlations. We found that support from family, friends, and a significant other was all associated with a lower energy density diet, which is indicated here by the green row. And then we also found that family support and support from a significant other was also positively associated with total fruit and veggie intake. And then for caloric intake, we also found a positive association with significant support from a significant other. However, when you put these in a linear regression model with covariates of education, age, income, and acculturation, the only factors that held were with energy density. And this indicates that more support from family, friends, or significant other may lead to you eating a better diet, because a lower energy density diet means that tends to mean that you're eating the healthier stuff. We also found that more significant association which indicates that more support from your significant other means you're eating more calories. That we should be taken lightly. Bigger samples for that one. Maybe you're eating with your significant other. I don't know. So the findings suggest that having social support from family, friends, or significant other may contribute to a low energy density diet, which was associated in a post hoc analysis that we did with a healthier eating index score. Future directions should look at maybe more specific vegetables, such as green leafy vegetables, which are associated with better outcomes for cancer reoccurrence. Also, other variables such as social constraints can also be looked at. And also more diverse populations of Latinas that don't live in New York City and have to drive a car to see what their activity is. Again, cross-sectional study, we don't know what came first, the chicken or the egg. We used self-report measures, and also the sample was mostly Dominican, and other factors such as social constraints should be considered. And thank you.
All right, thank you. So I'm going to be talking about healthcare experiences of the uninsured. This was prior to the Affordable Care Act, but I'm going to also update it with some data and also looking at some current statistics on COVID among the Latino population, Latinx population, nationally and in Connecticut. So my research was in Hartford, Malta House of Care, which is an independent, it's a freestanding clinic that was for anybody who didn't have, and to this day, it's still in existence. Anybody who doesn't have health insurance can go to this clinic, right? And they do primary care, and they used to go to 4 different sites, and I'll talk about that in a second. Okay. And when they go, the things that struck me when I went, because the clinic is at Catholic churches, so they're in the parking lots of Catholic churches, but because the Catholic Archdiocese of Hartford supports the work that they do. However, when I did my research, and to this day, two things that was very interesting that struck me is they do not ask for any religious affiliation. They don't proselytize. I even interviewed people who basically have no religion whatsoever. And they do not ask for your immigration status. And so quite a few of the patients that go to this clinic, of course, are unauthorized. Right? Not all, but many are. So this is the inside of a clinic. I don't know if you can see. There's the inside of the clinic. And it looks like an exam room, and then you would have a waiting area that's in the hallway there, where the patient can sit, or where the nurses would do their charting, or the physicians would do their charting. So it's just like a clinic that you would go to, when you're going to a clinic or doctor's office, but just in a much smaller space, obviously, right? And so this is the map of where the clinic would go. I said they would go to 4 different sites. So they would go to the Clay Arsenal area, which is in the north end of Hartford. They would go to St. Peter's Church, which was in the Park Street section. It was right on the corner of Park Street and Main Street, which was mostly a Latinx population that would go. They would go to St. Augustine's Church, which they still do, and St. Joe's Cathedral, right? So what happened was, because of gentrification, because of the baseball field that Duncan Park, right? Dunkin' Donuts Park, the clinic site had to switch. They could no longer go to the Sacred Heart Church, which is in the Clay Arsenal area in the north end of Hartford, because of parking issues. So what they did was they moved that clinic to East Hartford, to a church in East Hartford. But that means that the patients who could actually walk to the clinic, and Dr. Rojas talked earlier about clinics being close to your neighborhood. It was very convenient. Now they have to either go to another site, the one on Farmington Avenue, or they'd have to go to East Hartford, right, for their care, or to St. Augustine Church, which is in the south end of Hartford. St. Peter's Church also closed. And that was, again, supposedly, the structural issues of the church itself. And they found that they would need over $1 million worth of repair for the church. And the Catholic Church decided that it was too expensive to do that, even though the Catholic Church is one of the wealthiest institutions in the world, right? But they couldn't find the money to be able to help these marginalized communities, right? In their care. So they moved that, so they merged with a church in New Britain Avenue, but the clinic does not go there. So the clinic goes twice a week to St. Joseph Cathedral on Farmington Avenue. They go on Thursdays to St. Augustine Church, which is in the South End, and then they go to, so those are and then that's it. And the 2 in Farmington Avenue, and then St. Augustine Church, right? and the one in East Hartford. So that's just sort of a map of the area of where these clinics are, just a larger map. So the registration process, like I said, they would go in, and this is very interesting, especially thinking about unauthorized patients, because they would have to go in and register, and that still meant giving some kind of form of identification, right? So they would register, they would get a chart, they would have to get their history taken, some demographic information from the people who are registering them, okay? And it's a first-come, first-served basis, so there are no appointments per se. You just go in and you walk in, and you would get seen, if you come in the first one, you would be the first to get seen. And they would actually know, so what the patients would do would say, okay, who was the last person in here? And they would sit in the waiting area, and they would sit right next to the person who was the last person who came in. So they were really good about that, not like skipping the line, so to speak. And so that's the waiting area in one of the churches. And so they would just go and sit and find out who the last person was who came in, and would sit next to that person, okay? And so when I did my research, right, I was doing semi-structured interviews and participant observation, which was talking to patients as they were waiting in the clinic, okay? And so in 2013, when I was doing this research, this was the income level of the residents. And if you see the 2019 income level, it has changed slightly, but not a whole lot. So there's still quite a few that are making under $25,000 in Hartford. All right. New Britain is very similar. New Britain, 10.4% of the population, and Dr. Rose was talking about this, earn less than $10,000 annually, and 15.2% earn less than $25,000 annually. Okay. So there's high level of poverty, right, in these areas. Okay. So the ethnic background was pretty similar to my study in the clinic, based on the people that I interviewed, and then the overall patient population in the clinic. And if you look at the Hartford residents in 2013, the population was 16.7% white, not Latinos or not Latinx. And then Latinx was 43.4%, but in 2019, the Latinx population in Hartford was 44.3%, and the white, not Latinx, was 14.8%. So the white went down slightly, and the people, African American community, went up slightly. All right. And so I used a political economy of health, which is critical medical anthropology, and I used migration theory and migration and health and human rights to health, right? And syndemics, which is really an interesting concept that was developed by Dr. Merrill Singer, who actually happened to be my dissertation advisor. And syndemics really is about the interaction of two or more diseases in a population, and leads to thank you, to worse health outcomes. So it's a synergy of different illnesses, two or more different illnesses, but also the interaction involving multiple biological, psychological, and behavioral factors, right? And also the interaction between these types of diseases and health conditions, including infections, chronic non-communicable diseases, psychological mental health issues. Oh, hold on. Okay. So that's the synergistic process that that they look at, right? And so, thinking of the COVID the coronavirus, okay, which attacks respiratory and heart cells, and even cells of other organs. So it's most severe when it interacts with pre-existing respiratory or cardiovascular or non-communicable diseases like diabetes, asthma, high blood pressure, and even immune system disorders. So in Canada, the most commonly reported pre-existing health conditions that interact adversely with COVID-19 were cardiac disease, respiratory disease, and diabetes. Okay. And so a study of confirmed hospitalization patients from across China found that patients with any of these comorbidities, what we call comorbidities that I mentioned before, diabetes, asthma, heart disease, had poorer clinical outcomes than those without them, and that the greater number of other health problems suffered by COVID-19 patients, the less likely they were to recover. And social factors like poverty, population density, inequality of access to health care, incarceration, and homelessness are also likely facilitators of both illness and death in the pandemic. And then just thinking about migration, why people leave their home countries. And basically, there's actually more internal migration and others moving from rural to urban areas within a nation state than there is international. But certainly economic opportunities, low living standards, as was mentioned before earlier this morning, conflict and violence also is a cause for migration. Supportive social networks. People go to where they have a friend or relative, right? But today, as opposed to 30, 40 years ago, people are engaged in transnational processes. They still stay connected to their home communities in a way that they could not before. Paris Foster talked about this idea of, do I have that there? Okay, I must have missed it. Okay. Oh, okay. Is that migration trauma? No. All right. Anyway, so I'm going to talk first about this notion of migration trauma, right? And this was the work of Paris Foster. And Paris Foster talked about this notion of 4 stages, what she called stages of migration trauma. And the first is pre-migration, which talks about just the decision to leave your home community and saying goodbye to everyone that you leave behind. And then just the process of entering a new country, whether you're crossing the desert, and there was discussion about that this morning, or coming in via the airport via travel visas, is the second stage, right? Just trying to get into just the process of getting into the new country. Process of asylum seeking or resettlement, right? Finding a place to live, finding work. And often a lot of the immigrants, especially if you're unauthorized, they have substandard living conditions, okay, due to unemployment and discrimination, all right? And actually, when you think about this, and there's actually a real wonderful book that I actually have my students read, and they're reading now, is supposed to be The Land of Open Graves by Jason De Leon. And he talks about, living and dying on the migrant trail and the experiences that migrants have crossing into the U.S. from Mexico, right? And he talks about how that this idea of prevention through deterrence, right, and that the state system, the border agents and the government themselves actually, on purpose, make it difficult for migrants to come into the country through the fences and the borders and that kind of thing. The border agents, I mean. So these were some of the people that I interviewed, right? And a lot of this is still true today, where someone said, I came here to work, nothing more. And then another said, I stayed with relatives of my male first cousin. From there, they started to look for work for me, and I worked in a restaurant. So using these social networks, right, to find work, to find a place to live. And another woman from South America, I'm still helping my 2 daughters in Argentina and Spain. So what I earn here is not for me here. It's as if I have 2 houses. The economic reality is very hard, right? And I want to talk about this right to health, right? This universal right to health. And there's migration trauma, so I did through that already. Before I do that, this was a woman who crossed into the U.S. from the desert, and she walked. She thought she was going to walk for 6 hours, but the coyotes who she paid, and they pay enormous amount of money to do this, said, "Okay, you're at the border. You need to cross into the U.S. from here." And they were walking like 12 hours to try to get across, right? And she talked about how she took off her sneakers and her feet were full of blood, and they could not ventilate. And this was a woman who was a diabetic. So when the border agents found her, because she was really in bad shape, they took her to a hospital. And then a couple of days later, they released her and said, "Okay, you need to, go before the immigration authorities and see about, either going back or just report. You have to report to the immigration service, basically," which she did not. So she ended up going first to Maryland, where she had a family there. She was doing domestic work, but was being sexually harassed. So she left that job and came to Connecticut, where she had another relative. So the human right to health, right, is necessary for life with dignity. Everyone is entitled to access to health. It's connected to other human rights. But I was looking at this issue of deservingness and asking the people that I interviewed, who deserves health care and who doesn't, right? What do you think about this notion of deserving of health care? Who belongs and who doesn't, okay? And so this is what some of the responses that I got. Those who are citizens have a right to health care. We, as undocumented, well, we don't. And this was actually from someone who, she was unauthorized. She says, "Me, I recognize that I don't have a right because I am not from here. Everyone deserves it. Everyone deserves health care because we are human beings." So she saw this notion of deserving of health care as sort of different as being a right to health care. She felt that she deserved it, but at the same time didn't have a right to health care here in the U.S., right? And then another one, though, answered, "All of us are human beings and have a right to health care, and none of us look for illness. But there are people who have the best of everything, and they receive government assistance and medical care. But they have Dolce & Gabbana, brand names. I thought that they worked hard to get these things, but no. It's just that the government gives them everything. They don't deserve health care. They give them the blood sugar machine. I don't have the machine to test my blood sugar." And so there's this real tension between this idea of government, people who receive government assistance, and people who are unauthorized and can't get that kind of assistance, right? And in fact, there was a law recently that was trying to get passed in the Connecticut State Legislature, SB 596, that would expand Medicaid to everyone, all residents in Connecticut, regardless of immigration status. And it got a favorable report out of committee, and this was in May, just this past May, but it failed in the emergency session. It just died, right? And then here's another example of this notion of deservingness. The right comes after doing something. I'm always talking about productive people. We have a right always, and when we contribute. Deserving, that's more complicated for me. Human beings deserve just for the fact that they are human beings. Everyone, white, black, yellow, rich, poor, everyone deserves. But the right itself is earned by doing something, okay? So the Affordable Care Act, which we still have, right, was passed in 2010. It is not a government-run health plan. And one of the issues that people talk about when I interviewed them, and people who even were able to get get health care through the Affordable Care Act, is about the high deductibles and the low premiums. Or you can get low deductibles, but you have to pay high premiums. And at the time, there was very limited knowledge about the Affordable Care Act and who could enroll and who couldn't. Right. So in this case, the key findings is that the political economy of the modern global society is directly involved in healthcare, right? The uninsured rate in Connecticut right now is almost 5%. It's 4.8%. But an estimated 52% of the undocumented immigrants in Connecticut, of which 62% are from Latin America and 11% are from the Caribbean. This is from the Migration Policy Institute. They are uninsured, okay? And there was this tension, as I said, between how participants think about the right to health and deservingness and the migration trauma that affects immigrant participants' health. And then the challenges limited to primary care clinics, which was great. You know, they felt wonderful that they could get their primary care taken care of, diabetes, high blood pressure. But then they were concerned. I remember that some of them would say to me, what happens if I get cancer? Where am I going to go for care? I'm uninsured, I'm unauthorized. And so, you know, they wouldn't even go for mammograms because it was even if I go and I find out that I have a lump, there's nothing that I'd be able to do about it, right? Which is really tragic, and I think, you know, really unfair. But anyway, and so the overriding concern, of course, too, was finding work, of course, with health benefits, right? That's basically it. Future outlook, we're dealing with the budget, national policy, and I just want to talk a little bit, about the impact of COVID. In COVID among Latin Americans in the U.S., in Latino counties, only account for 11% of the counties in the Northeast, right? And this is a population where Latinos are greater than or equal to 17.8% of the population. 4% of counties in the Midwest and 33% of counties in the West. Nonetheless, they comprise a disparate proportion of COVID cases in each region. Now, in Connecticut, as of the end of September, and this is from the Kaiser Family Foundation, you had Latinos or Latinx were accounted for 11% of all the deaths due to COVID. And they were 17% of the total population. And you can compare that to the percentage of deaths of whites and the total population and blacks or people of African descent, right? And then you have here the cases of by race ethnicity. And this is also 65%, where data was available for 65% of the cases. And for 65% of the cases, you had 18% of all COVID deaths were among the Latinx population. And they make up 18.45% of the U.S. population. That's the reported deaths, right? Which were 84% of reports of data about ethnicity regarding COVID deaths. 65% cases reported by ethnicities, and these are data from the CDC, and this was, again, as the end of September, as of October 9th, right? 26.6% of all cases of COVID are among Latinos, okay? And then this is just another data point of COVID deaths among Latinos, and you can see the darker the color, the higher the deaths of Latinos, right? So you have, for example, California was 40% of all COVID deaths were among Latinos, and they make up, 47%, but they make up 40% of the population in California, right, which is really quite high. In Florida, it was something like 23% of all COVID deaths were among Latinos, and they make up 27% of the population in Florida. And Texas, again, is also very high, right? Anyway, I can give you these slides, I'll give you those links if you want. But about 2/3 of Hispanic adults and again, this was very recent, have said that they are worried that they or someone in their family will get sick from coronavirus, including 41% who say they are very worried, right? And this was based on interviews that the Kaiser Family Foundation did with 778 Latinx adults in the U.S., okay? And 408 of them were born outside the U.S., including 185 who indicated that they were unauthorized. All right. The higher level of worry is not unfounded, as Latinx adults are more likely than white adults to report close connections to someone who has gotten sick or died from the coronavirus. Nearly 3 in 10, 28% of Latinx adults say they or someone in their household has tested positive for the coronavirus, higher than the shares of people of African descent or whites. And the share of Latinx adults born outside the United States, including 40% of the potentially undocumented. The share rises among this group. About 4 in 10, 38%, say a close friend or family member has died from coronavirus, similar to 34% among African Americans, and higher than 18% among white adults. All right. And they said 48% of Latinx adults say the pandemic has had a negative effect on their personal financial situation. Again, higher than the share of white adults who say the same thing, 36%. Okay. And among those who have a lower income, under $40,000 a year, 56% of Hispanic adults say their financial status has been negatively affected by the pandemic. Again, higher than African Americans or whites. Okay. So I want to end with a couple of really great quotes. Well, I like them. And this was from the late Subcomandante Marcos in the Zapatista region of Southeast Mexico. I was there in the 1990s during the Zapatista uprising, and I was there working at one of the clinics that the Zapatista, the indigenous people themselves, built because they were not could never rely on the government to give them any health care. So they decided to take matters into their own hands and got doctors to train them. So they had promotores de salud, health promoters, and people who could actually treat their own people in their own language. And so, I was there because to help out in the clinic. And what was so interesting is that they were really good. They were bilingual, so they would speak their indigenous language, but they would also speak Spanish, so that I could basically translate for them for the some of the doctors that were coming from the U.S. To support the Zapatistas, right? And so what the late Subcomandante Marcos says is, in our dreams we have seen another world, an honest world, a world decidedly more fair than the one in which we now live. We saw that in this world there was no need for armies, peace, justice, and liberty were so common that no one talked about them as far-off concepts. And Naomi Klein wrote in her book, The Shock Doctrine, The Rise of Disaster Capitalism, she wrote, it was in 1982 that Milton Friedman wrote the highly influential passage that best summarizes the shock doctrine. Quote, only a crisis, actual or perceived, produces real change. When the crisis occurs, the actions that are taken depend on the ideas that are lying around. That, I believe, is our basic function, to develop alternatives to existing policies, to keep them alive and available until the politically impossible becomes the politically inevitable. And so with that, I thank you. Oh, and I just wanted to put a shout-out thank you to the library staff, Martha Croy and Joy Hansen, who helped me a great deal with pulling some of the statistics together. Thank you.
So I think there's quite a bit of time for questions or clarifications, anything you might have for the panelists, anything we had so far this afternoon even.
I have a question. I have some policy students in Romania. For both of you, what are the policy implications? What kind of policy would you like to see as a result of your research? What could be established at policy levels to sort of improve the conditions that you guys are in the situation?
I think at least from the perspective of interventions, is more of a focus towards prevention, right? And funding the prevention. The problem with a lot of NIH sponsored interventions is that the interventions don't leave the ivory tower. They stay there. And it's how do we disseminate these interventions and how do we sustain them, right? We know that eating healthy, we know that physical activity is literally the free medicine for all of this. But we're not disseminating the information. We're not making it easy for people to prevent cancer. There's a big tie to cancer and obesity, to prevent cardiovascular disease, to prevent diabetes. So it's more focused on prevention and then making it easier for people that are impacted, like more likely by it, and to get access these resources. So I don't know if you guys ever heard of the Latino minority immigrant health paradox. So it only applies to specific groups. It doesn't apply to all Latinos, specifically Puerto Ricans. Their health habits tend to be more consistent with the general population of the United States. But it really ties to like the Mexicans that do come here. They actually have a healthier diet than your typical United States resident. However, by being in the United States, they adopt our unhealthy eating habits and physical activity habits, and then as they stay here longer, they technically are at higher risk for all these diseases. So there's even more of an effort to get these immigrant communities that do have these healthy behaviors to get them to maintain them so that they're passed on generation to generation. So.
So as I mentioned before, this was called SB 956, right? And it's called an act providing medical assistance to certain individuals regardless of immigration status. And I said before, it received a favorable report in May. This was in the Connecticut State Legislature, but then fell through. And there's always the question, and in thinking about even national policies, is how much is this going to cost, right? But I think the more important question is what and who do we lose by not providing health care to everyone, right? I think about all the potential knowledge, right, that young people or people who are unauthorized could contribute if they had good health care and their health care was taken care of. I mean, all of the potential opportunities that we as a society are losing by not providing health care to everyone, regardless of immigration status.
So just real quick, I have a question here on migration trauma. And again, trauma is coming up, and it is so important to understand, and I think more and more in the medical and geography and health literature. That. Let me just ask the first question.
Excuse me, everybody, no one online can hear if it's not said into the microphone.
They can hear if it says, at least from Walton listening in.
Okay.
Hi, Walton. But anyways, just real quick. If you want to go to the microphone, it's fine. It's just the fourth migration. You said it, trauma. Right. Pre-migration, process of entering, resettlement, and then up substandard living. Okay.
So what I found when I would do these interviews, I actually go to the houses of these of the patients that I would interview them in their homes, in their apartments or whatever, and you could see. I mean, it was really sad because you would have people that just lived in one room, and they would have multiple people living. You'd have 4 or 5 people living in a two-room apartment building, right? So the issue of crowding and just living conditions were just so difficult, right? And again, it's because of pooling their resources just to be able to make ends meet.
Are there any other questions, perhaps? I had one for Amanda. I was curious in terms of, you have this very detailed data, it's very granular, and I was wondering what were some of the takeaways in terms of the question you raised about the difference between outcomes for Latinas with social supports as opposed to the general studies that you had.
So specific to social support, we know if you look at research that looks at Latinos in other fields, it's always about familismo and family and how it's important to the Latino culture. And then when I'm looking at health interventions, I'm like, well, how come no one has focused on targeting social support, having more people involved versus just targeting the individual? And there's literally 2 or 3. And specific to cancer, it's how do we get them to, prevent cancer, because cancer could come back, right? Cancer reoccurrence. So I would like to take this research and replicate it in a larger sample with more diverse Latino groups, but also try to create an intervention where it involves a breast cancer survivor to bring at least one family member, right? If you teach the other family member, they'll have someone to hold them accountable for their acts, for their eating, their physical activity. But at the same time, you teach that person how to hold them accountable correctly, right? Because as we know, not our whole families are not very good at giving us feedback or being the most, supportive person, right? So you have to teach people to be support. We think because you have people that are in your social support network that they're actually good at it. No, they're not. So to teach people how to be good social support networks, and also to teach them these eating and physical activity requirements and how to meet them.
Well, we've had such a great afternoon so far, and we have one more panel, but I think we can take a short break now, and I'm going to consult with the next panels. We'll either be back at 4:30 or 4:15, but thank you very much for coming, and we'll see you soon.